people with diabetes are at risk of kidney disease, and our focus will really be on how to keep those organs healthy. And I just want to remind everyone that if you have a question during the interview at all, just to type it in the Q&A box, and we'll address it at the end of the presentation here. Just a couple other things. We will be recording the presentation tonight because we will be posting it hopefully online at a later date. So just keep that in mind. And I do want to let everyone know that the Canadian Diabetes Association is partnering with the Kidney Foundation for the webinar tonight, so that's great. And I have also noticed that there are a lot of people tuning in from the East Coast, so hello. I also noticed a few other people tuning in from Maple Ridge, Abbotsford, Kamloops. So I just wanted to thank everyone for being here tonight. We really appreciate it. And with that, I will hand it over to Dr. Anthony Booth.
Thank you very much, Jessica, and thank you all for giving me an opportunity to talk. I'm absolutely delighted to do it. And I've pitched the talk assuming that the audience is very much patient-based, but I'm very happy to adapt according to the questions to tailor it to any healthcare professionals or physicians that are in the audience. So I will try my best not to confuse you all. My own background is I arrived here in Nanaimo on the Vancouver Island about 6 years ago. I was in the UK in Oxford and Cambridge for many years, and then came to Canada on a fellowship, postdoc fellowship, and decided to stay. So I've been here for about 6 years, and the bread and butter of my practice has been diabetic kidney disease. So with that, we will start, I think. So the objectives of tonight are to try and are essentially fourfold, to try and understand what we mean by kidney disease, because if we're talking about diabetes in the kidney, we really have to understand what kidney disease is in the first place, how we define it. And then we'll talk a little bit about how diabetes itself affects the kidney and try and understand that process. And then there are many other influences on kidney function. Many of you know people or are indeed diabetic, and there is often, very often, a high prevalence of hypertension or high blood pressure in patients with diabetes. And together, those effects of the blood pressure on both the kidney, the influence of diabetes and hypertension on the kidney can be quite devastating. So it's very important that we understand other influences other than diabetes itself on the kidney disease process, full stop.
Dr. Booth, I'm sorry to interrupt, but you sound clear, but you just sound very quiet.
Oh, okay. Can you hear me now?
Yes, that's so much better.
Is that better? Okay.
Thank you. Yeah.
So, excellent. Thanks, Jessica, for that. So I'm not sure how far we got, but understanding how diabetes itself affects the kidney, and then the other influences of high blood pressure, which is very prevalent in patients with diabetes and kidney disease, is important to recognize that and treat it to try and slow the progression of the disease down. So, and then finally, we'll talk about things that both you as patients and me as physician will do to help slow the progression and potentially to prevent disease in the first place. Am I speaking loud enough, Jessica?
Yes, if you could go even a little bit louder, that would be great. But Lynn just typed that you're very clear, so that's good.
Okay, great. So well, I'll do my best.
A lot better.
So if one was to define kidney disease, one has to consider both a blood test and the urine. And it's very important that when physicians, general practitioners, or specialists are talking to you as patients about kidney disease, that we don't detach those two phenomena. So it's extremely important to know what your blood is doing and what is in the urine. From a blood perspective, we measure something called a GFR. which is really a measure of filtration from the kidney. And we define kidney disease as anything with a GFR of less than 60. So you can see here in this slide there are 5 stages of so-called kidney disease. The white line in the middle here is defines 60%, if you like, and anything lower than that, where my arrow is here on the computer, defines kidney disease by definition. So if your GFR, or filtration rate, is less than 60, we say, by definition, we have kidney disease. It can also be over 60 if in the urine we have protein on the little dipstick that's done in the urine, or blood in the urine too. Or if we have structural kidney disease, some people might have cysts in their kidneys, and some people may have had autoimmune conditions like lupus or vasculitis, and they may have GFRs of over 60, but have evidence on a biopsy or on imaging or in the urine of abnormalities like protein or blood. But this is just a very crude picture of the glomerular filtration rate and the stages of kidney disease. I don't want you to get the impression that patients in stage 1 automatically progress all the way down to stage 5, because that's not correct. It's just a means of setting the parameters here, so it doesn't imply progression. So just to recap, anybody with a GFR of less than 60 or those over 60 who have abnormalities in the urine will have, by definition, kidney disease. That is the blood. And then that's the blood. And then the question then is that GFR, or filtration rate, about which so much depends as patients when people are talking to you about kidney disease. It's important we just backtrack and understand how that was derived. So that was an equation derived from patients with kidney disease a number of years ago, and they pop your age and the creatinine, which is a breakdown product of muscle, and your gender, whether you're male or female, into an equation, and out pops this so-called glomerular filtration rate. And it's important to recognize that that equation was validated in these patients with kidney disease, none of whom were diabetics. So there's a potential problem with introducing the filtration rate into you or people you know with diabetes in that context. And it's very easy to potentially overestimate the severity of the disease in this sense. So I only mention that because it will come up for other health professionals that may be tuning in. So the important thing is, in the blood, we look at the GFR filtration rate. And then in the urine, I've just put a little picture there of a cup of urine because they're so important to unite those when people are talking about kidney disease. And in the urine, we look for protein in the urine or blood, hematuria there. Now the protein, you'll get results back where the doctors have ordered a dipstick of the urine, and they may have ordered an albumin-creatinine ratio or a protein-creatinine ratio. Both of those are markers of amounts of protein in the urine. So just to recap, because it's so important, so all diabetics with a GFR of less than 60, we say have chronic kidney disease. All diabetics with a GFR of over 60 can still have kidney disease if they have protein in the urine. The next slide, we talk about how diabetes might influence the kidney function. And the high sugars over time often combined with high blood pressure, cause aging of the glomeruli. If you can imagine a tadpole with a head and a long tail, the head is the glomeruli, and that's full of little blood vessels. And those blood vessels have holes in, essentially, little fenestrations. And the sugar and the blood pressure work to alter the filtering of the blood into the urine there. And so you get changes in structure in the kidney, which then leads to progressive loss of function, loss of filtering. And you get scar formation, and then that sets up protein in the urine. And the blood pressure exacerbates all of that process. So the questions you want to ask your family doctor is, what is my GFR? And do I have any protein in the urine? Now, they might talk in terms of microalbuminuria, and they may talk in terms of macroalbuminuria. The microalbuminuria is less than 1 gram of protein in the urine, and the macroalbuminuria is over 1 gram. And that's important, and we'll come to that in a minute. So what's my GFR, and do I have any protein in the urine, and is it more or less than 1 gram? The normal is less than 0.2 of a gram. So then the question is, if I do have kidney disease, what is my chance of progression? What is my chance of going on ultimately to develop kidney failure? Now I've just put some statistics here based off older literature. And what you can see here is if you were type 1 diabetic, by 15 years, about 20 to 30% will have small amounts of protein in the urine, microalbuminuria, less than 1 gram. And that's the same in type 2 diabetics. Around 25% at 10 years would have small amounts of protein. About 10 to 15% of people would have the larger amounts of protein in the urine, over 1 gram. And in the old series, 16% would be on dialysis over a period of about 20 years estimated, so 16% chance of developing dialysis dependence. Now, your family doctors and other healthcare providers, nurses, nurse practitioners have done a fantastic job in promoting the importance of controlling diabetes and controlling blood pressure over recent years. And the success of that is that people like me don't see the large numbers of patients with large amounts of protein in the urine, and much fewer are developing the need for dialysis. You've definitely slowed the progression of the disease through the management of just simple things like blood pressure and better control of diabetes. So that now the recent data would say only 2 to 7%, rough average 5% of patients with type 1 diabetes would ever go on to dialysis dependence, and about 0.8% of type 2 diabetics. So dramatic improvement in the overall prognosis from kidney patients with diabetic kidney disease. So the next question is, having identified my chance of progression, how quickly should I see my kidney function fall? It's quite natural aging process for the kidney function, the GFR, to fall at just under to close to 1% a year over the age of 30. So if one had diabetic kidney disease but no protein on the left here, I would expect a loss of function of about 1 to 2% a year. On the right-hand side of this slide, I've said diabetic kidney disease with protein in the urine, we're losing about 5% a year. Now that is very variable, and these are ballpark figures, but 1 to 2% a year if you don't have protein, and 5% a year if you do have significant protein in the urine. So what are the influences on the progression of the kidney disease? In this slide, in the top, I've shown you diabetes itself. And there's no doubt the worse the diabetic control, the worse the aging of the vessels in the tadpole head, and the worse the filtration over time. And controlling the diabetes down to HbA1cs of around 7% has been shown to significantly slow the progression of kidney disease. I mention here metformin because it's important to recognize that as the kidneys, if they do decline down to filtration rates of 30% as opposed to 60%, it's very important that we should think about removing metformin altogether. Not because metformin is would necessarily damage your kidneys, but it is associated with the development of acid in the blood and various complications. So once your GFR is less than 30, I would encourage you to come off the metformin. Now, the kidney controls, to some extent, not only the glucose production of the body, but also the breakdown of insulin. And as the kidneys misbehave, so it is easier to develop hypoglycemia, or low sugars, as the kidneys progress. And so you'll find the doses of drugs will likely reduce, particularly insulin, as the kidney function progresses. There are two, instead of using glyburide, which is very long-acting and associated with frequent low sugars in patients with kidney disease, we tend to use either gliclazide, which is a shorter-acting form, or repaglinide, which we use at mealtimes. You can use some of the newer gliptin drugs, but you have to tailor the dose down accordingly. And as I say, the insulin requirements will fall. But controlling the diabetes, particularly at an early stage in kidney disease, can significantly slow the progression of the disease down. Jessica, am I speaking too quickly?
No, it's perfect, and you're loud and clear.
Okay. The next thing on this slide, I talk about hypertension or high blood pressure. I'm very often asked about the relevance of office-based blood pressure readings versus home recordings versus 24-hour blood pressure readings. Many of the earlier major trials were using blood pressures based off office readings. It's become very apparent, particularly in more elderly patients, that the home blood pressure readings are often lower than those of the office, which raises concerns with us targeting higher levels in the office for fear of lowering your blood pressure too much and then causing dizziness, instability, and then potentially falls with hip fractures. So there is more and more data now coming out showing that we can rely on home readings. And the target blood pressure, certainly at home, should be less than 135 in the systolic, the top figure, during the day, and 125 at night. So the targets are often used for patients with kidney and diabetic disease of 130/80. I think the evidence to support that from big trials is fairly tenuous, but we should certainly be targeting less than 135 during the day and 125 at night. That is the systolic blood pressure. I'm emphasizing the systolic blood pressure because as we get older, we tend to move in terms of hypertension from diastolic hypertension, the bottom figure, to more systolic-based hypertension, which really reflects stiffness of our blood vessels as we get older. So those are the targets, and I personally approach this in slightly differently. If the home readings are with a machine that is well correlated with your general practitioners or with the pharmacies out in the community, if they read the same when you take them to those individuals or places, then I'm happy to rely on the home readings. If there's any discrepancy, then I tend to use or request a 24-hour blood pressure monitor, which will also give us the readings at night. There are other reasons to use 24-hour blood pressure readings, but those are the main ones. The next thing, in terms of reducing blood pressure, I'm often asked about the role of salt in the diet. Now, when one reaches for a packet of peanuts as you're watching a ball game, or a packet of chips, what the body's response, as you know, is you feel thirsty immediately. So the salt is laid on the chips and the peanuts, you take it in, and the body's response is to make you thirsty, to drink water. And that's a typical physiological reason for that. And it also releases a hormone that goes to the kidneys to try and retain water. Now that salt and water then builds up, and you can imagine if you keep that in a glass and you expand the salt and water, the pressure is going to rise. And so long as you're exposed to a high salt diet, the pressures will stay high. And then as you move off the diet, your kidneys are smart little beings, and they will excrete the salt and water, so to bring your pressure down. Very often, in patients who have difficult to control blood pressure, they tend to be very salt sensitive. But not everybody is salt sensitive. But that's my message for you with regards to salt, which can be very influential in patients with blood pressure, high blood pressure. Many diabetics who are also hypertensive or have high blood pressure and kidney disease are often have often got a lot of salt and water retention, and they predispose to a higher risk for obstructive sleep apnea. And that itself can be associated with higher pressures, and treating that can, in some studies, bring the blood pressure down further. I'll talk to you about the ACE and ARBs in a minute. High body mass index, increasing weight gain, can be associated with swelling of the tadpole heads in the kidney, and can make the protein worse, the protein leak worse. So high body mass index is very important as a means of potentially slowing kidney disease down, but as part of a reduction in hypertension and improvement in diabetes, targeting the high body mass index is important. There are many patients who unfortunately have a family history of other relatives who have kidney disease, close relatives, and our First Nations population tend to be at higher risk of kidney disease through genetic influences. These are not single genes, but many, many genes, and we have to be mindful of that. Smoking itself can also be associated with progression of the kidney disease, likely through vascular aging, blood vessel aging, which will then age the kidneys. And cholesterol, high cholesterol, was originally thought to be associated with progressive kidney disease and at higher risk for cardiac events. In fact, treating cholesterol has not been shown to improve kidney function, but it does reduce cardiovascular disease, so risk of heart attacks and strokes. There are drugs to avoid and medication to avoid. The anti-inflammatory drugs, some of which are over-the-counter, like ibuprofen, and then others, indomethacin, naproxen, Voltaren, just to mention a few, as well as Celebrex, can cause the kidney function to decline faster, and it's unpredictable, unfortunately. And we're not smart enough as physicians to work out who are more predisposed to developing aging of the kidneys with these drugs. So in those who certainly have kidney disease, I would definitely advocate avoiding those. There are certain herbal remedies which are used, and some of those ingredients have been shown to be associated with kidney failure, particularly those with aristocolic acid. That's A-R-I-S-T-O-C-H-O-L-I-C, I think it is, aristocolic acid. And then finally, any products that you get over the counter that have heavy metal base to them, or chromium, for example. Heavy metal compounds have been associated with progression of kidney disease. Finally, you will find that water pills can cause a reduction in swelling in the legs. But the downside to that is that they can potentially cause reduction in volume in the blood vessels, and then the kidney function can drop associated with them. So we just need to be mindful of that. And your physician should talk about that when they're prescribing. The question of diet comes up, and from a diabetic point of view, I've told you, we've already mentioned the importance of diabetic control, and the typical diabetic diet would be very important in patients with kidney disease. The low salt discussion we've just had. You may be asked to lower your potassium intake. And the reason for that is that the kidneys don't handle potassium as well, particularly if one has diabetic and kidney disease. And so as the potassium rises, you may be asked to pursue a low potassium diet. So only if the potassium was rising. I wouldn't advocate that for everybody. Protein restriction has been advocated in a number of studies. I think that's very debatable, and I think the evidence for that is extremely tenuous. Until one gets to kidney function that's quite significantly impaired down to well under 30%. And then low phosphates people will often pursue. That tends to be in the later stages of kidney disease. Phosphate products would include milk and chocolate and dairy products and cheese. So in this slide here, I've talked about normoalbuminuria, which essentially has little or no protein in the urine, to the micro, which is less than 1 gram, to the macro, which is over 1 gram of protein in the urine. And this arrow implies progression, which is not necessarily true at all. Certainly, if we have over 1 gram of protein in the urine, this is associated with not only increased cardiac events and stroke risk, but is associated or can be associated with progression towards kidney failure. That is not so true in the case of microalbuminuria, where one has less than 1 gram. So if you have less than 1 gram, A, it's potentially reversible, and B, it does not necessarily mean you're going to progress to kidney failure assuming that diabetes is the underlying cause. There have been a number of trials, which I've hinted at here, designed to try and reduce the progression from one to another. from the normo to the micro, and the micro to the macro, and the macro to the end-stage kidney failure. And the renal and the IDNT studies, which used irbesartan and losartan, really did show significant reduction in progression there and improved outcome in terms of mortality. The other two show can be associated with slow progression, but have not necessarily altered the mortality. That's a complicated slide, and I don't, for 1 minute, I would not be concerned if I didn't understand all of that slide. And I'm happy to come back to that at questioning. The kidneys themselves control many other aspects of your body, and as the kidneys misbehave, so anemia can become more evident because the kidneys send messages to the bone marrow to produce red cells. And as the kidney function declines, so the message is not there, and therefore you become anemic. That's important because we rely on assessment of control in diabetes using the HbA1c. Now, unfortunately, if the red cells are not hanging around in the system for very long, which they are not in patients with kidney disease, then the HbA1c, which relies on coating of the red cells with sugar, will be, to some extent and very frequently, but not exclusively, lower than we would expect for the degree of glucose control. So as the kidney function heads down, I tend to rely on the home glucose readings rather than the HbA1cs. The kidneys also, I told you, are important in controlling potassium. And if the potassium builds up too high, it stops the heart. So it's important that the potassium is monitored and a low potassium diet is pursued. Particularly, as many patients are, they're on a combination of spironolactone and or an ACE inhibitor such as ramipril or perindopril. That combination, particularly as the kidney function misbehaves, can cause high potassiums and then upset the heart. The kidneys control the bones, and what happens in kidney disease is that there's increased bone loss and higher turnover and increased risk of osteoporosis. And there are ways in which we can treat that to potentially slow that progression down. And I've talked to you about salt and water and high blood pressure. So those are the major complications of kidney disease. Often asked how frequently we should be monitoring our bloods as patients with kidney disease, and this just gives you a framework which I think is not unreasonable. So this is how I tend to approach it, which is that if I've got a kidney function of over 60%, then I tend to do it every 6 months, and if it's under 30%, I do it every 3 months, and if it's 15 to 30%, I do it once a month. This frequency will vary depending on how quickly one is moving through or one is declining. So what are the symptoms to look out for if I had kidney disease? As one's kidney function drops down towards 30 or below, fatigue and lethargy can be a problem. Because we don't excrete the water and salt as well, as efficiently, or we may have coincidental heart problems, we might get short of breath through the buildup of fluid. We may not excrete toxins as well, and these toxins lead to itch, and so you might get itchy. So fatigue, lethargy, breathlessness, itchiness, and nausea and anorexia, and a frequent complaint in patients with more severe kidney disease is a metallic taste in the mouth and just a complete lack of appetite. One can have sleep disturbance either through obstructive sleep apnea or also because depression has got a higher incidence in patients with kidney disease. If you look at the urine, and if you have lots and lots of protein in the urine can look frothy. and it can be a sign of significant protein. There's often just there are bubbles down at the base of the pan, but if the bubbles start to climb up the side of the pan, then that is more indicative of higher protein leak. The next slide shows what I would expect if my kidney function got down under 30%. I would encourage you to ask to be sent to a kidney care clinic. The reason for that is that it's a multidisciplinary clinic made up of nurses, social workers, dietitians, and sometimes pharmacists. And what I think the purpose of that is not only to educate and arm you with lots of information and on a frightening topic in many ways, but also enables them to assess symptoms and plan for the future in terms of the kidney disease. Many, many of you will not progress with kidney disease, but some do, and I think it's important that early planning allows for better outcomes, and that's been shown in many trials. So in the kidney care clinic, one would assess the symptoms, would assess the blood pressure and help alter that in partnership with the family physicians, would help assess the diabetes, and then looking at the complications of kidney disease in terms of anemia, the bones, the acid, and potassium. Again, not designed to frighten you, but just to give you knowledge. Because my dream is always that a patient would come through the door and say to me, this is where my kidney function is, this is how much protein I've got in the urine, I've changed by X% a year, I don't feel any complications at the present time. That would be a success. Now, I mentioned to you early on in the presentation that the progression of kidney disease through those stages down towards development of dialysis dependence has fallen with the success of management of high blood pressure, diabetes, and the introduction of so-called ACE inhibitors such as ramipril, perindopril, and some of the other equivalent drugs such as irbesartan and Renal. They have really slowed the progression of kidney disease. And the reality is that in those of us who have declining kidney function, the much greater hurdle or obstacle or risk to us moving forward is the risk of a heart attack or stroke. And this slide is rather complicated, and I'll try and simplify it. On this axis, we've got the rate of death from any cause, but in fact, what I want you to, or encourage you to read, is cardiovascular events on this axis here. Just imagine that says heart attacks or strokes. And this, on this axis, it shows the decline in kidney function from 60%, 45 to 60, 30 to 44, 15 to 30, and down under 15. And what you can see is these bars here rise significantly, these columns rise significantly as the kidney function declines. So what it's saying is that our risk of heart attacks rises almost exponentially as the kidney function falls below 45%. So not only have one had this success through nurses, nurse practitioners, and family practitioners in terms of management of the diabetes and blood pressure, but we're also fighting the increased risk of heart attacks and strokes moving forward. And I think, therefore, it's very important that kidney disease just forms yet another vascular risk factor, in addition to smoking, diabetes, high blood pressure. And it's a marker of vascular aging. I hope I haven't confused you here. I did have other slides, but I just want to confine it to these few slides here and give you a chance to ask me questions. And I'm delighted to answer any that I can. And I thank you for your attention.
Great. Thank you so much, Dr. Booth. There's a lot of information in there, that's for sure. So I'm sure people will begin to type in their own questions. Iris has a question right off the bat here, and I'm going to go with the abbreviated versions of these words because I'll butcher them. Dr. Booth, I'm sure you'll know how to pronounce them properly. Are EPA and DHA in an EFA supplement safe to lubricate the joints after trauma?
As in to use as topical therapies for, from a kidney perspective. I'm not aware of any evidence, Jessica, that those are toxic to the kidneys when taken topically over the joints in that situation. So I don't, I'm not aware of that. What is a concern is the use of anti-inflammatories. And the problem with anti-inflammatories is the unpredictable effect on the kidneys. And the topical anti-inflammatory we use frequently, topical Voltaren, for example, is frequently prescribed. And by definition, some of that is absorbed. The data on the risk of topical anti-inflammatories on kidney failure is still very naive, Jessica. So there are case reports, but have not been shown large studies showing there is a significant association with the topical therapy. I would not take any oral anti-inflammatories. But I'm not aware of any DHAs or EPAs that are toxic in that respect.
Okay, so Iris put a follow-up question. These are taken internally. Does that make a huge difference?
Again, from a kidney point of view, I'm not aware of any toxicity associated with any of those synthetic androgens, DHEAs, and other supplements in that regard.
Okay, and Heather wants to ask you, Dr. Booth, can you explain how when the GFR decreases, people with diabetes are more prone to hypoglycemia and consequently need less meds/insulin?
Yes, okay, that's an excellent question. So as the kidneys are major influencers on the metabolism of insulin and the what we call gluconeogenesis. So the creation of glucose substrates. And so as the kidneys decline, the half-life of insulin tends to rise. The breakdown of insulin tends to be less efficient. And so the insulin itself hangs around for longer, is a simplistic way of thinking about it. And therefore, one's going to be more prone to hypoglycemia. Moreover, some of the drugs used to treat hyperglycemia, such as the sulfonylureas and other of the products like the gliptans, are metabolized through the kidney. And so basically, as the kidney function declines, those drugs will potentially be more effective in lowering sugars. Now, and so we tend to use lower doses. And then I think that's probably the easiest way to do it. So the kidneys are not as efficient producers of sugar, or gluconeogenesis tends to fall, and the consequence of insulin presence becomes more significant, and so you become hypoglycemic for that reason as the kidney function declines. I hope that it answers that question, Heather.
That was a great question. Is low vitamin D commonly associated with kidney disease?
Right. It's another very good question. And the answer to that is no. What typically happens as the kidneys decline, so the phosphate in the blood tends to rise because it's not excreted from the kidneys. Added to that, and so in response to that, there's a hormone called parathyroid hormone which rises, and that's the thing that causes higher bone turnover. But with regards to vitamin D is taken in by mouth, and it's synthesized in the skin, as you know, and then goes to the liver to be activated, and then finally to the kidneys. So as the kidney function declines, the activated form of vitamin D tends to decline. Vitamin D itself, the levels of those are not always low in patients with kidney disease. It's the activated form of vitamin D that is activated in the kidney, where it's taken vitamin D to activate it, that tends to fall. I hope, does that make sense?
Yeah, no, that makes sense.
So when you have kidney disease, for example, it makes sense to bypass the vitamin D and go straight to the activated form of vitamin D as their replacement.
Okay. And I have a question from Philippe. Could you explain a little more about how dairy products can affect the kidney?
Right. It's like, I was making that reference in terms of phosphate. And one of the problems when the kidney function declines is the phosphate tends to rise. Now what happens is that phosphate will bind to calcium, and that essentially forms chalk-like substance, and that will cause accelerated vascular calcification and aging of not only the small vessels but the large vessels. So higher phosphates, for example, are associated with cardiovascular events. And the phosphate in the diet is predominantly based around the substances you've just said. So we like to reduce that significantly to help reduce phosphate intake, knowing that high phosphate is bad for you in patients with kidney disease as we progress. And then we often find that we put people on phosphate binders to help reduce that absorption of any phosphate further, if you see what I mean.
Okay. And I have a question here from Gwen. Does one normally feel cysts in the kidney? I've had many problems in the past with cysts that caused much pain and required surgery, but first time having cysts in my kidney. Presume this is the cause of pain I'm getting.
The cysts, many of us get cysts in our kidney and kidneys as we get older. There are other triggers for cyst formation, and there are genetic syndromes associated with cystic kidneys, so-called adult polycystic or polycystic kidney disease. And so many of us are wandering around with cysts that don't cause us any problems. They can cause problems as they get bigger, in the sense that they can cause discomfort if they're significant size and starting to compress other organs, or they can develop infection. You can bleed into a cyst, which would give you pain, and they can predispose to stone formation. So depending on the situation, yes, cysts can cause symptoms. The difficulty is managing the cyst, because if you just stick a needle in to drain the cyst, very often the cyst will come back, whereas to formally remove a cyst is a much bigger procedure. There are ways to sclerose and scar a cyst up, but again, more invasive procedures. So the answer to the question is, most of the cysts as we get older tend to be asymptomatic, but yes, indeed, larger cysts can cause complications either through bleeding, infection, or stone formation.
Okay. And I have a question from Jeannie for our next question. My GP doesn't encourage me to see a specialist. On diabetes, she wants me to go to a clinic only. Can I ask to see a specialist, and would it be better for me?
It's a very good question, and it's a frequent question. And I think what I would do is exactly as Jeannie and her GP have potentially agreed there, is I would want to start in the clinic first. The nurses are hugely knowledgeable about not just the management of the diabetes, but also the management of the other associated factors. And it gives them access to dietitians, to social workers, to pharmacists, and many more people in that regard. If, having been to the clinic, we're either not succeeding in lowering our HbA1c or risk factors, or you're not happy with what's been said, then I think it's very reasonable to then go on and ask to see the specialist. Very often, as you know, specialists have long waiting lists, and often a quicker way in to them is through the clinic, because if they're having problems controlling sugars, they will very often consult with the specialist anyway.
Okay. Our next question here, Dr. Booth, is from Franca. Is daily blood glucose monitoring different for a person living with diabetes and kidney disease, i.e. using a blood glucose monitor than using special test strips?
I'm so sorry, I don't quite understand.
Is monitoring is a daily blood glucose monitoring different for a person living with diabetes and kidney disease? Like, would they have to monitor their blood glucose differently?
No, I would, especially if you're not on dialysis. It can be different when one's on dialysis, but with non-dialysis-based kidney disease, I would treat them the same way. What I was trying to the point I was trying to make was that HbA1c's become difficult to interpret if you become anemic as a result of kidney disease. But I very much rely on the glucose monitoring, and I think provided you've got an accurate monitor machine, I don't see why it would make any difference which technique you used.
Okay. I have another good question from Heather here. She says, I understand how smoking can make compromised kidney function worse, but is smoking considered to be a risk factor for developing CKD?
There are, the answer to the question is, it is a risk factor for CKD insofar as there are a couple of large studies which have shown associations, Heather, between smoking and kidney disease. What they have not shown, and probably will never prove because of, from an ethical perspective, is a randomized trial showing patients randomized to smoking or not smoking. Will that improve kidney function? So there is an association between smoking and progressive and kidney disease. But have they demonstrated that stopping smoking improves outcome? To my knowledge, that's not true. That's not been found, not been demonstrated.
Okay. And another question from Philippe. Why should herbal remedies be avoided?
I'm not saying that all herbal remedies should be avoided, and I think it's a good question, Philippe. It's coming up more and more. The problem for me is that with regards to herbal remedies, that I tend to be very purist. So I've not seen a large number of randomized trials demonstrating that herbal remedies improve outcome. There are many case reports, but not large studies. And so advocating for herbal remedies is, I find, very difficult. But equally, I can't, there are very few situations where I say the herbal remedy is harmful, so I can't offer an opinion. However, there are certain herbal remedies which are associated with the development of kidney failure. And one of them is anything containing aristocolic acid. And what I would do is encourage you to look up the association between the herbal remedy you might take and the development of kidney disease before you take it.
Okay, I think that's good advice. Okay, I have a little bit more of an in-depth question now. First off, very interesting presentation, Dr. Booth. My mom recently had a significant drop in GFR from 27 to 18 in a 6-month period. She's 89 years old and diabetic type 2, but stable blood sugar. No cardiac symptoms evident. Any comments or thoughts? And then she put in brackets, metformin has been discontinued a while ago. Recent BP is 140.
Yes, very common problem and extremely relevant. And my approach to this is that fluctuations in kidney function are typically either due to volume-related changes. So patients who, particularly as we get older, may not be taking as much fluid in, so may not be drinking enough, or who have been given diuretics to get them to pee out more fluid in recent times. So the commonest cause of a drop in kidney function tends to be due to volume and hypovolemia. The other causes can be due to ischemia, and by ischemia I mean lack of oxygen from thickening of the blood vessel wall and lack of oxygen to the kidney, and blockages in arteries. So ischemia is one manifestation. That tends not to be reversible, whereas if you increase the fluid intake, the kidney function very often improves if it's due to volume. So those are the first two. The other causes are heart failure, nephrotic syndrome, or liver failure, which would become more apparent, and I think she's hinted at that those aren't relevant in her mum's case. The other causes could be obstruction for any reason. Again, more often in men, would look for obstructed ureters, which might cause decline in function, and obviously rule out any toxins that we've discussed. Or if she's suddenly developed blood in the urine, one has to think of other causes such as immunological disease. But the commonest cause is typically due to reduced volumes.
Okay, I have more of a comment from Daphne, or a request. She says she would love to have a discussion on diabetes and naturopathic medications, as many patients are now taking, and it was raised again tonight, and I don't know much about supplements. I have concerns about diabetes, hypertension, and kidneys, and what supplements are safe.
Right. Again, an increasingly difficult problem. Again, I have no, I don't criticize people taking supplements because I've never seen any evidence in large trials that the majority of them are harmful in any way. So I'll only comment if I know that something is harmful. I just throw an anecdote out to you. And it relates to the fact that unfortunately a lot of the supplements are not perceived as drugs and therefore not regulated by the FDA. And the difficulty with that is that you're never too sure exactly what strengths of substances you're getting within the supplement. So you might be getting a lot of goodies, but there may be many, many hundreds of times concentrations. And there was a case that was written up in the literature with somebody who was taking over-the-counter vitamin D supplement, who had 2,000 times the concentration of vitamin D in the supplement. And it was that was associated with the high calcium, such that when they stopped the supplement, everything normalized. So again, that is an anecdote. I am not making the statement that all supplements in any way bad. The problem I have is that I haven't seen any randomized, I haven't seen a significant number of randomized trials in patients with kidney disease who are taking the supplements. The problem with the supplements, again, is if the supplements contain higher heavy metals, those are associated with progression of kidney disease. So you want to know whether or not you've got, really you want to know what the concentrations of each of the things are and whether or not there's any heavy metal in there. Okay? Okay.
Perfect. Well, I'd just like to put out the call if anyone does have a lingering question. We've had some really great questions so far. I've been really impressed with them. So if you do have another question or a follow-up question that you would like to put to Dr. Booth, don't be shy. There's no such thing as a bad question. And as we can tell, he's able to answer all of them. So ask away. And Dr. Booth, in closing, just while we wait, if any more sort of questions come up, what are the takeaways that you would want participants to take away with them from this presentation?
Okay.
Like if they could have sort of two things that they could remember or change in their diet, would it maybe be sodium intake? What would your takeaways be?
I would encourage you to know exactly what your kidney function is to start with. And remember, we said our kidney function includes the GFR and the urine. So I'd want to know where I am to start with, and also what my chances of progression are. Those are the two things. And then the third thing is I would thereafter like to make sure my blood pressure is under good control, that my diabetes is under good control, and if I'm diabetic, should I or should I not be on a cholesterol-lowering medication? At the end of the day, Jessica, the kidneys are a marker of vascular health, and our biggest risk moving forward is heart attacks and strokes, and those are the major challenges for us moving forward.
Okay, well, my call for questions worked. So Iris, are herbal supplements regulated in Canada?
I'm not best placed to answer that,
Yeah.
actually. I don't, I'm not sure of the answer to that question, actually.
Okay, no worries. That's not really your realm. Michelle wants to know, can you discuss the difference between albumin creatine ratio and protein creatine ratio?
Yeah, Michelle, excellent question. The albumin creatinine ratio, as it states, is albumin, which is filtered through the little tadpole heads. The protein creatinine ratio is the total protein in the urine, which includes albumin, but also includes the proteins released from the tail of the tadpole. So the protein creatinine ratio is, to me, a better marker overall of protein loss from the kidney. But most of the trials were all done with albumin creatinine ratios. To give you a reference point, the albumin creatinine ratio of over 60 means that we're over a gram of urine, and a protein creatinine ratio of over 100 is a gram. So I hope that answers that question.
Okay, no, yeah, certainly. And we have a question from Gwen. I've had a eGFR as low as 45, but now it keeps going up and down, currently down to 58, and in brackets 63 in the last quarter. How hard is this on the kidneys when it keeps fluctuating like that?
Yeah, it's a very good question, Gwen. And as I said to you, the commonest cause, particularly in that case when it's bouncing around like that, is due to volume. And so I would ensure, first of all, that I'm maintaining, assuming the heart allows, but 1,500 mils of fluid at a time. And often, when one's sent for fasting samples, we can sometimes interpret that as meaning that we shouldn't have anything to drink from the time we go to bed, such as whatever it might be, 8 o'clock in the evening. And that's potentially a problem because it means you arrive for the test dry, and therefore the kidney function will be lower. And even if it is a fasting test, you're allowed to drink water. So I'd encourage you to continue to drink fluid through that time and ensure that you're not left dehydrated, because then you get people like me and other healthcare professionals worried about these fluctuations. Now, the question long-term is whether or not these are harmful to the kidney function, and in time, there is some data to suggest that fluctuations in GFR can be associated with slightly worse kidney outcome. But it very much depends on the cause for the fluctuations.
Okay, and Michelle, question from Michelle here. In someone with established kidney disease and diabetes, you have a great table for frequency of measuring GFR. How often should ACR or PRCR be measured?
Yes, another very good question. And I tend to, if I've got, I tend to get the last few years' worth of data first, and assuming that the albumin creatinine ratio or protein creatinine ratio has been going on for a while, I tend to do that every 3 to 6 months, depending on the degree of protein leak. So if I've got over a gram or 2 of protein, I tend to do that every 3 months, and otherwise every 6 months.
Okay, and another good question from Heather. In your earlier chart, there was an indication that after 15 years with type 1 diabetes, there is about a 5% chance of progression to ESRD. Does this imply that if after 15 years with type 1 diabetes, the GRF is over 60, there's little chance of CKD?
After 15 years,
with type 1 diabetes.
With type 1 diabetes, if you do not have protein in the urine, you're very likely to be fine for the rest of your life from a diabetic kidney point of view. There may be other influences in terms of vascular risk and heart attacks, but the chance of developing end-stage renal failure by 15 to 20 years in one study suggests that there is around a 5% chance of developing that. So 95% chance you don't go on to develop end-stage kidney failure. You may be left with chronic kidney disease, but not at the profound status of kidney failure per se, as in end-stage kidney disease.
Okay. Can ARB/ACE inhibitor help preserve kidney function in a diabetic person?
Absolutely, and that's what we were hinting about in the trials. So if one has any protein of significance, particularly over a gram, there is a very good evidence that being on an ACE or an ARB, which are things like ramipril or irbesartan, can slow not only the progression of the kidney disease down, but reduce the risk of mortality. In patients who have microalbuminuria or less than a gram, one can slow the progression to macroalbuminuria, and the difficulty is you're not necessarily improving mortality. They haven't demonstrated good significant mortality improvement in that. So you can think you're doing the right thing targeting the protein, but they haven't necessarily improved mortality. And the final thing was that if you've got a normal blood pressure and no protein with diabetes, I would not necessarily advocate starting on an ACE or an ARB at that point. I would wait for the protein leak or the blood pressure to rise before doing that.
Okay. Well, Dr. Booth, thank you so much for your time. Your presentation was informative, interesting, and you were also able to answer all of the questions here. One last one from Michelle. Because of its action in the kidney, what are your thoughts on the new to Canada diabetes medication Invokana? Am I pronouncing that wrong? Have you heard of it?
Yeah, oh no, I haven't. I've never prescribed it. I would have to go and look at that. I'm so sorry. I've seen it being prescribed, but not in my patient population so far. So you'll have to forgive me on that. Oh, sorry. Okay, no. It's a glucose co-transporter. Right. Yes, we've been waiting for these, and the difficulty is the data out when the kidney function is significantly impaired. So I think I'd want to look very closely at the evidence for use in patients with significant kidney disease, i.e. GFRs of less than 30 in this situation. And also they are associated with increased urinary tract infections. That's the other thing that may make me nervous. So I haven't followed the SGLT2 inhibitor data yet sufficiently to give you an educated opinion on that. And I've certainly not seen any mortality advantage in patients with kidney disease and diabetes using that drug.
Okay. Thank you so much, Dr. Booth, for your time. And thank you to everyone who attended the webinar tonight. And, of course, for all of the wonderful volunteers who helped coordinate this session. There's a lot of work that happens behind the scenes that you all don't see. And we would like to remind everyone that you'll be sent an evaluation survey tomorrow, and of course we encourage you to complete it. It should only take about 2 minutes, and it does provide valuable input for the Canadian Diabetes Association. And I'll just briefly talk about the Canadian Diabetes Charter. It's a grassroots initiative to empower the diabetes community. If you haven't heard about it, you can check it out at mydiabetiescharter.ca. The development and delivery of impactful programs such as our new Canadian Diabetes webinar series is made possible through the generous support of our donors. If you enjoyed the webinar and would like to make a donation, please visit our website at www.diabetes.ca or call 1-800-BANTING. Thank you everyone for your support and of course for all of your great questions and for participating in today's webinar. The next webinar will be on Wednesday at 7 p.m. Pacific time, and it's all about diabetes support. So we'll be talking about tax credits, kids in schools, and travel. So there will also be a lot of valuable information to go over on Wednesday. Thanks again for your time, Dr. Booth, and have a great night, everyone.
It's a pleasure. Thanks very much for listening.